talk to us about mental illness and risk of venous thrombosis, which I thought Jala was going to talk about, but now I read it's her title is to be confirmed. Jala, do you want to tell us what you're going to talk about today?
Sure. I'll talk about stress-related pathways to mental health outcomes using 2 of my research examples.
Okay. So take it away, Rona, mental illness and the risk of venous thrombosis.
Are you able to see my screen? Nope, I'm at the end of the presentation, not the beginning. That's always a good start. Still, sorry about that. There we go.
Yeah.
Okay, so thank you for coming and listening to some of my research today. I'd like to start by thanking all of my collaborators, both here in Glasgow and in Barcelona. So epidemiology has long suggested and proven a link between severe mental illness and increased risk and burden of cardiovascular and metabolic diseases. So by severe mental illness, I'm mainly talking about schizophrenia, bipolar disorder, and major depressive disorder. I am in no way minimalizing the effect of other mental illness, but for the purposes of this talk, that's what I'm discussing. When I talk about cardiovascular and metabolic diseases, that's more heart attacks, stroke, venous thrombosis, obesity, diabetes, whole cluster of traits that are very common together. So it's clear that there are many complex relationships between socioeconomic, lifestyle, environmental factors, as well as genetic predisposition and treatment effects. Genetic studies recently have started to show that there might be underlying shared biology that's connecting mental and physical illness. One study showed that if your genetic risk for obesity is increased, you have an increased risk of depression. And if you have an increased genetic risk of depression, your risk of obesity increases. So a bidirectional link there. Schizophrenia and glycemic control appears to be more unidirectional, but hasn't fully been investigated. So this study set out shared mechanisms contributing to mental illness, thromboembolism. So venous thromboembolism, which I will refer to as VTE because it's easier, consists of deep vein thrombosis, that is typically a blood clot in the lower leg, which causes pain and swelling and can be treated, and pulmonary embolism. So when you treat deep vein thrombosis, or if it's not treated, a fragment of the blood clot can detach from the main blood clot, move through the circulation until it reaches the small blood vessels in the lungs and causes a blockage. This is quite often fatal. So there is discussion as to whether deep vein thrombosis and pulmonary embolism are one disease entity or whether they are 2 different things. But for the purposes of this study, I've combined them, which is also very common to do in the field. So VTE is a rare event, but it's frequently fatal. Risk factors include non-O blood groups, rare genetic variants that influence the coagulation system, obesity, smoking, female hormones, so pregnancy, contraception, HRT, menopause, all increase the risk of VTE, cancer and cancer therapy, and immobility, such as you would have during long-haul flights or lower limb breakages, which are then put in a cast. Individuals with severe mental illness have additional risk factors, as in sedation, during a psychotic episode, catatonia, which may be a feature of depression. In addition, antidepressant and antipsychotic medications have an increased risk, though it's not entirely sure how and why. Although these medications also increase the risk of obesity as well. So it's a bit of a circular increasing problem. It's hard to predict who will experience the VTE. People with many risk factors may never have an event, whereas those with very low risk factors could have an event that could be fatal completely out of the blue, seemingly with no particular instigating factor. In contrast to heart disease and stroke, venous thrombosis is considered more about how your blood is, how sticky your blood is, how likely it is to clot, rather than the blood vessels. So for the first part of this study, we looked at across the whole genome, how similar are the effects, sizes, and directions of genetic variation on venous thrombosis and mental illness? The idea here is the genetic variants across the genome are having similar effects on both traits. Maybe they're shared mechanisms. If there's no evidence for similarity in effects on VTE and severe mental illness, then it's unlikely and there's no point continuing this study further. One thing to point out is the venous thrombosis data was from a trans ancestry analysis, whereas the mental illness results were from European ancestry analyses. So here are the results. If I draw your attention to the RG column, this is effectively a percentage. So it appears that between venous thrombosis and depression, there is about 18% shared overlap in genetic risk. 18% of the genome is consistently having its effects on venous thrombosis and mental illness. And that was significant, whereas the analyses for bipolar disorder and schizophrenia were not significant. It's possible that these analyses underestimate the overlap because of the ancestry differences, but that's something we cannot look at further at this point. So then we decided to look at UK Biobank study, which for anyone who is not aware, is a large study of 500,000 participants across the UK. There's a lot of genetic data, phenotypic data, lifestyle, self-reported mental health, and cardiovascular disease phenotypes. For this study, for genetics, we used unrelated self-reported white British ancestry individuals, self-reported data on venous thrombosis, which were either deep vein thrombosis or pulmonary embolism or both. Controls were those who said, no, I have not had that, and anyone who said they didn't know was excluded. We also excluded rare clotting disorders. So for this study, for each individual in the analysis, we calculated the polygenic risk score for schizophrenia, the polygenic risk for bipolar disorder, and the polygenic risk for depression. So essentially here, we're counting up for each individual the number of mental illness increasing genetic variants that are present. We can then use the polygenic risk scores to assess genetic risk of these diseases for impact on venous thrombosis. And we used a couple of different models, adjusting for age, sex, population structure, and genotyping chip, that's standard for genetics, and then additional covariates to see about the stability of the association. We looked at sex-specific and sex-combined analyses, and our sensitivity testing involved removing anybody who had ever reported having a mental illness. So the sample size was pretty reasonable. We can see that pulmonary embolism is more common in men than in women. The rates of deep vein thrombosis were similar. And importantly, when we excluded individuals who had ever reported mental illness, the proportion were similar in cases to controls. So the results. Here we're looking for a p-value less than 0.0173. That's corrected for 3 polygenic risk scores tested. And we see that schizophrenia, very little to report. Bipolar disorder, there is an association in women, but not men, and sex combined, it stays the same. And then strong associations were found for the polygenic risk of depression for impact on increasing risk of venous thrombosis, irrespective of which model we used. The sensitivity testing. So firstly, we removed anyone who self-reported mental illness, and that had no effect on the results. They stayed stable. We also tried switching out removing polygenic risk score and adding family history of severe mental illness in a first degree relative. And again, the results were very similar. And this point is quite clinically relevant in that we can't use genetics clinically at the moment because not everybody has genetic data available. But if a clinician can ask, when doing a risk assessment for venous thrombosis, if they can ask one more question of, did your parents or siblings have severe mental illness? That could be quite important and quite an easy thing to incorporate into clinical practice. Obviously, it needs to be replicated first and proven that this is not just a random finding. And another thing to bear in mind is UK Biobank is relatively healthy, so it's possible that we're underestimating the effects. We have tried to replicate these findings. The only data set that have got back to us so far with results has shown completely null findings.
You know, you get like a kind of bimodal distribution. I wonder if it's like.
Sorry, somebody else is talking or could be on mute maybe. Sorry, thank you. So these results were null, but this is a very small data set, so it's possible that they were underpowered. So in summary, we found an overlap between genetic risk for depression and venous thrombosis. The results were stable in men and women, irrespective of the model used, irrespective of removing individuals with self-reported mental illness. And if you use family history instead of polygenic risk, the results are similar. So we are waiting for replication. I'm presenting this work at the International Society for Thrombosis and Hemostasis conference, which has a big genetic section. And I'm really hoping I'll get some enthusiastic people to repeat the analysis at that conference. And with that, thank you very much for your attention. And if you have any questions.
I have lots, but I'm not going to jump in first. So anybody else put your hand up or shout out? Lots of clappy hands, which is good. So the depression and venous thrombosis and obesity might be a sort of interesting mix. I'm guessing, although I can't think of a paper off the top of my head, that there is a connection between obesity and venous thrombosis, and you've indicated that there's a connection with depression and obesity, and you can also see that depression, obesity, smoking and other risk factors might play in there. So to what extent do you think that there is a sort of common ancestor, as it were, and these are two expressions of another disease?
Yes, it's we do need to do further work on this to try and understand what's going on. One thing I'm trying to get funding to do is to look at the polygenic risk scores for major depression with the collaborators in Barcelona and look at all the different coagulation markers to see if there is an effect of genetic risk of depression on the coagulation system. If there isn't, then yes, it's probably being driven by obesity or smoking. But I think it's then possible to, if we look at the polygenic risk for depression and for obesity and for smoking, with all the coagulation factors, maybe we can start to tease out what may or may not be happening.
And then observing stuff going on and watching people die is, okay, it's a reasonable academic pastime, but ultimately we want to interfere beneficially in the process. And so as a clinician, I'm sort of looking for, you know, what intervention might sort of sit in here. And the obvious one is a GLP-1 receptor agonist, which reduces obesity. There is experimental evidence to show that GLP-1 receptor polymorphisms are associated with depression. But that, of course, might be linked through obesity. So, you know, there is also animal experimental evidence to suggest an impact on thrombosis. So, when you're looking for your polymorphisms, you know, it might be good not just to treat them all the same, but perhaps focus down on GLP-1 receptor agonists. I think
it's also something that maybe in psychiatry clinics, they should be potentially more aware of this increased risk, because if there's also family history of venous thrombosis, then those individuals are probably at quite a high risk already. So if they're not successful in using lifestyle to reduce their obesity, maybe they should be checked more often to then, try the GLP-1 receptor agonist therapy, depending, of course, on how they interact with all the other drugs that these individuals are being prescribed.
Yeah, but there's so much debate about the efficacy of antidepressant therapy at the moment, which you're more aware than I am. I know there's some recent stuff suggesting that if you use combinations of agents, they might be more successful than single agents. But the single agent approach doesn't seem to be, seems to be controversial from an outsider.
But it is interesting that this link between antidepressant and antipsychotic medication, which on its own seems to increase risk of blood clots. I mean, you expect antipsychotic and antidepressants to be working on the brain. Is there something else? Is it acting on another system as well that's causing an increased risk? So there's the depression, there's the treatments. It's all very messy, but that's kind of what makes it interesting.
Well, I'm sure that serotonin has something to do in all this. But if you treated the obesity, might that not help the depression?
Yes and no. Yes.
For some people, then.
Because treating obesity and reducing obesity is good for all sorts of reasons, not just how happy you might be in yourself. But also there is this thing of your genetic risk of obesity, irrespective of what your BMI is at any point in time. But if you have a higher genetic risk, you're more prone to depression. So it might work better for people who are at the lower end of the obesity genetic score. Yeah, I look forward to a day when politicians and funders keep telling me it's likely to happen, that everybody individually has genetic data that can be put into clinical practice. And then I think we'll have the numbers possible to study and look longer term at the effects and be able to do these big studies in a population, divide people by their polygenic risk and see what treatment they've been tested on and what works and what doesn't. Yeah. Tiny incremental steps.
Okay. So, any other questions? I think that was quite an interesting discussion, and maybe something useful come out of that. So, so it's over to Jala. I've forgotten your title already. So I'm going to start with the title and take it away.
Sure, I'm just gonna try and share my screen here. Obviously, this isn't working right now. I need to change my system preferences. Sorry, I'm not in my office, so.
You're in a nice office.
Yes, it's much more glamorous than my actual office.
Anton Muscatelli's, no?
Let's see if this works now. Yeah, I think this is working. Okay, can you see the full screen?
I think so. It's very dark in there, but it saves energy.
I use dark backgrounds. That's for sure. So thanks for having me today, and thanks, Rona, for your talk. Today, I'll be talking about stress-related pathways to mental health outcomes using 2 of my research examples. But before I do that, I thought I'd just offer a bit of context. I joined the university last year as a lecturer in clinical psychology. Before that, I was completing my postdoctoral fellowship at the Hospital for Sick Children in Toronto. So in preparing for today, I wasn't so sure what to focus on, especially that most of the research that I started during my time at the university is still underway. What I ended up deciding doing is using 2 of the research examples that were completed and published in 2021 to show some of my interests and in stress-related pathways to mental health outcomes, which is something I'm continuing to work on at the University of Glasgow. So hopefully I'll make a link between this completed and published work with ongoing work at the university. Let me just minimize these. thumbnails because I cannot seem to see anyone. Okay, great. So I'll start with my broad research goals and context, and then share findings from 2 published papers. I'll also highlight the application and implication of my research program and link to ongoing work and future work that I hope to conduct during my time at the university. So generally, I'm interested in studying diverse pathways from early vulnerability, trauma exposure, to emerging mental health difficulties in young people especially, but across the lifespan too. Identifying those pathways while taking into account diverse groups and their unique trajectories allows for the tailoring of individualized preventative efforts. And ultimately, I hope to use this research that will have potential to inform equitable policy to ensure that mental health services are allocated properly and are accessible to those most in need. So briefly, and as a reminder, trauma exposure, which encompasses stressful life events, victimization, adversity types, traumas, include things from childhood abuse in the home to exposure to community violence or natural disasters, as well as experiencing chronic illnesses. All of these things together are widespread in our community. We find that based on data pooled from 24 countries, 70.4% report exposure to at least one trauma type. 30.5% report exposure to 4 or more trauma types in their lifetime. So it's needless to say, these are high proportions. And not only are the rates of exposure substantial, but they are also consequential. So we know that exposure to one type of trauma increases risk for further exposure, increasing the risk of developing chronic illness such as diabetes, heart disease, and blood pressure, in addition to addiction and mental health disorders. And so it's important for individuals' well-being and public health costs to address the impact of early trauma early in development. And with that, I will use 2 examples from my research to show some of these pathways. In the first research example, I conducted a study during COVID-19 pandemic, and I highlight economic and psychosocial factors that may increase vulnerability to negative outcomes. The second example demonstrates the negative psychological sequelae of trauma exposure at an individual level, highlighting some important areas for psychological intervention, particularly within the context of trauma experience and risky and self-destructive behavior. And hopefully we'll have time for both examples, but if not, we'll settle for the first one. So to start with the first example, at the start of the pandemic, several commentaries highlighted the impact of COVID-19 and associated restrictions on marginalized groups and families with pre-existing vulnerabilities. I think it comes as no surprise to anyone that COVID has had a disproportionate impact on certain groups in our community. The point being that some families are already strained due to experiences of, but not limited to, discrimination, having a child with a mental health disability or a physical disability, or being of a low socioeconomic status, such that there is not enough room to handle or accommodate additional stress posed by the restrictions and the pandemic. So I wanted to empirically examine and better understand what factors make some families susceptible to the negative sequelae of COVID-19. When I conducted this study, there was very little work with children and youth. It was mostly on vulnerability factors and outcomes in adults or parents reporting on their well-being and its impact on children. So this is where the research collaborative on COVID and mental health comes in place. So the COVID-19 and mental health project was put together and initiated as a rapid research response to the pandemic's impact on mental health. It was initiated through collaborations at SICKIDS. The primary goal was to understand the impact on mental health within families in Ontario, in Canada, particularly children's mental health. In this collaborative, there are 2 clinical cohorts, so the psychiatry research SICKIDS and the POND cohort, and 2 community cohorts, Spit for Science and Target Kids, and there's more detailed information about them in our paper. The project itself is longitudinal, so it allows us to measure and monitor the impact of the pandemic across time and development. One of its core strengths is that it has cohorts with a good representation of children with neurodevelopmental disorders and various other mental health conditions, which is a rarity in research on mental health during COVID-19, unfortunately. Okay, so I used data from both parents and children across 2 time points between May and November of 2020. Parents reported on demographics, including child mental health diagnosis, ethnicity, and pre-pandemic socioeconomic status, as well as on material and economic deprivation due to COVID-19, on parental stress due to COVID-19 restrictions, and parent and child mental health, including depression, anxiety, hyperactivity, and inattention. Children 10 to 18 years of age also completed their own measures of stress and mental health. And you'll see the number of participants we had. So we had 1,069 parents and 441 youth. That's at time 1. And of course, we see attrition at time 2. Just generally, an overview of participant characteristics at time 1. The ages of the children ranged from 6 to 18. About 60% identified as European and European ancestry, and 65.5% had a pre-existing mental health diagnosis. And this is a child having a pre-existing mental health diagnosis. You can also see that the sample is quite affluent based on their household income prior to COVID and parental education. Okay. For the analysis, before I get into the results, I used confirmatory factor analysis for measurement models and structural equation models to estimate vulnerability pathways to mental health outcomes during COVID-19. And I'd be happy to address any questions about this approach if needed. One of the major questions was, to what extent have families experienced material and economic deprivation due to COVID-19? You can see the impact was substantial in this sample. So 35% reported moderate to extreme worries about financial instability. 27.7% reported worries about living situation instability. Almost 10% reported food insecurity, and 12% reported job loss. Finally, 24% reported reduced ability to earn money. So these are, again, considerable rates in our sample, especially considering their pre-COVID socioeconomic and educational status. So now that we have an estimate of the extent of the material deprivation in the sample, I use structural equation modeling to estimate pathways to stress and mental health. Bear in mind that I also controlled for age and sex in the models I'm presenting on. So this is what the model looked like, and it fit the data well. I'll walk us through the main pathways in this model. First, what makes certain families more susceptible to this deprivation than others? Here's material deprivation due to COVID-19. I identified 3 risk factors: a child with a pre-existing mental health condition, lower socioeconomic status, and being of a non-European ancestry, all predicted higher material deprivation due to COVID-19 restrictions. I will stress, though, that the mental health diagnosis and socioeconomic status were stronger predictors than the child ethnicity or ancestry. Then we see that higher material deprivation was associated with higher parent stress and parent and child mental health symptoms at time 1. Those 3 in turn predicted worse family functioning, as well as higher stress and mental health symptoms at time 2. So we see the impact over time. Importantly, we find cross-lagged or reciprocal associations with parent and child mental health having a reciprocal effect on each other over time, and so does mental health symptoms and stress, with a stronger path from parent and child mental health to parent stress. So this is an important takeaway, because if we address mental health, it could potentially buffer the impact of restrictions on parental stress, perceived stress. Okay, so I also estimated a truncated version of the model using child and parent reported variables. Remember, I had youth self-reports as well. So a strength here is the multi-informant aspect of the model. And this is what it looked like, and it fit the data well again. Material deprivation and family functioning in this model are based on parent report, while the mental health and stress measures are based on youth report. We see that material deprivation as reported by parents was associated with higher youth-reported mental health symptoms and stress at time 1. These in turn predicted worse family functioning as reported by parents at time 2, and higher youth-reported stress and mental health at time 2. So again, we see the impact over time. What's important is that the consistency across the results, and we see the reciprocal effects between youth mental health and stress, similar to what we found in the parent report model. And again, we find a stronger pathway from mental health to stress, highlighting the point that if we address mental health or vulnerability due to pre-existing mental health conditions, we can potentially allow or help support children and families buffer the stress from an ongoing pandemic and public health crisis. So in terms of key implications from this example or from this study, several implications are notable. I've summarized them and I've highlighted 3 here. Material and financial support at times of public crises is warranted, especially for the most vulnerable, to buffer the impact on material deprivation. Both child and parent mental health services are vital, which will likely help to mitigate the impact on perceived stress over time and allow more room to tolerate further restrictions potentially or further stressors. Support, and finally, support to reduce stress due to isolation and restrictions by allowing for opportunities to socialize and network in adherence with public health guidelines is also warranted, considering stress did still have an impact on mental health at the same time, but also at a later time. So we see cross-sectional and longitudinal effects. So this concludes the first research example. And I think we have enough time to go to the second one, but please stop me if you think this is enough. But now for the second example, I'd like to show a research that demonstrates the psychological sequelae of trauma exposure's effect. And again, the findings are taken from published work from 2021. And in this examination, we focus on individual level factors or mechanisms that can be assessed and targeted in treatment, rather than the broader, more contextual psychosocial factors that I highlighted in the COVID example. So we know that trauma exposure increases the risk for engaging in risky and self-destructive behavior, including such behaviors as self-harm and drug use, but not everyone exposed to trauma will engage in those behaviors. So what are some of the mechanisms that contribute to these outcomes? I looked at the indirect effect of 2 cognitive and emotional mechanisms. So one was individuals' assumptions about the world and the self, and those assumptions are thought to reflect one's understanding of the benevolence and meaningfulness of life and the events that take place in one's life, as well as reflect how one views themselves and their self-esteem. Trauma exposure can increase one's negativity in any one of those 3 domains or main assumptions that we have. Emotion dysregulation is the second mechanism I looked at, and it refers to a constellation of abilities, general abilities, including the ability to choose adaptive strategies to regulate emotions and behaviors, the ability to be aware and accepting of emotions, to manage impulsive behavior in the face of heightened negative emotions and distress. And we know that those skills are also implicated in risky and self-destructive behaviors, as well as in trauma exposure. So the goal was to integrate these mechanisms and trauma-related outcomes into one model to test both the direct and indirect effects and pathways. For this study, we used a cross-sectional design and recruited a sample of 270 participants, and this is a university-based sample. Their ages ranged from 16 to 39. They completed measures of trauma exposure, symptoms, assumptions about the world and the self, emotion regulation skills, and risky and self-destructive behaviors. Before I go or show the pathways tested, I just thought I'd highlight and characterize trauma exposure rates in this sample. And you'll see from the rates here that they support the prevalence of various types of trauma exposure in the community and the validity of using a university sample. The ones in blue refer to childhood exposures, and you'll see that it ranged from 10% for childhood sexual abuse to 41.1% witnessing domestic violence as a child. I would like to also note that 66.8% of the sample reported more than one type of trauma exposure. Taken together, those are considerable rates, despite the sample being recruited again from a university. I used path analysis to model the hypothesized pathways, and this is what it looked like. And again, I'll walk us through it in a second. But first to note, the model was estimated using data from participants reporting exposure to at least one traumatic event. And again, the model fit the data well. Here, solid lines represent significant regression coefficients, and the dashed lines are not significant. Okay, so let's start with the first set of pathways, which were from trauma exposure to negative assumptions about the world. And we see that higher cumulative trauma exposure was associated with higher negativity in the three assumptions and beliefs, but it was, when put together in the model, it was only significantly associated with benevolence and self-worth. Then, in turn, we see that negative beliefs about self-worth partially mediated the association between trauma exposure and trauma symptoms, but the latter remained significant. So there was still a direct effect from trauma exposure to trauma symptoms, and that's why self-worth is a partial mediator here. Then higher symptoms, higher trauma symptoms, were significantly associated with lack of access to effective emotion regulation strategies and difficulty regulating impulsive behavior when distressed. Eventually, though, only difficulty regulating impulsive behavior when distressed offered an indirect path from trauma symptoms to risky and self-destructive behavior in the past month. Trauma symptoms, though, continued to have a direct effect on the latter, whereas trauma exposure only had a direct effect on lifetime engagement in those behaviors. And so the point of this model is to test these pathways together, test the direct effect and the indirect pathways to identify potential targets for intervention along the sequelae of trauma exposure. Some key takeaways from the results and from our findings is that there's evidence that trauma exposure continues to be a risk factor directly associated with increased psychopathology or trauma symptoms and lifetime engagement in risky and self-destructive behaviors. So appropriate intervention remains a priority recommendation in this area. Self-worth in particular plays an important role in the perpetuation of trauma symptoms. Clinicians in this case can utilize cognitive strategies to work with individuals to rebuild what Janeth Willman, for instance, called shattered assumptions, which may help mitigate trauma symptoms and their ensuing consequences. Effective treatments for trauma symptoms or psychopathology may be particularly important to explore with individuals who engage in risky and self-destructive behaviors. Because, I'm sorry here, I keep having a pop-up, but as I said, so effective treatments for the trauma symptoms can include trauma processing, exposure, and so forth when that's ready and warranted in a treatment plan, of course. And finally, impulsive behaviors when distressed. So a key here is that it wasn't the lack of access to effective emotion regulation strategies that offered an indirect pathway, but it was actually the impulsive behavior when distressed is the one that offered a key pathway, an indirect pathway to risky and self-destructive behavior, supporting the likely function of these behaviors to escape distress or extreme emotions. So some strategies that can be used in treatment include distress tolerance and emotion regulation training to address those areas or concerns. And so with that, I can conclude the two research examples that I used here. Eventually, I'd like to continue to examine both vulnerability and resilience pathways to mental health outcomes in young people as a function of early exposure to stressful and traumatic life events. But importantly, I'd like to integrate my approaches so that I can include both individual and systemic factors in the same model, and utilize predictive modeling potentially to identify young people most vulnerable to stress and its cascading effects, so we can start using individualized preventative approaches. And certainly this research program has widespread application and implications, and accounts for both, clinical, developmental, and global issues in the pursuit of child and youth well-being. And during my time at Glasgow, I hope to again continue to develop this program and incorporate other situations such as climate change threat and stress, and continue my work on child maltreatment and its negative sequelae on development and mental health outcomes. And with that, I will stop. Hopefully I didn't lose most of you. I'll stop my screen.
Thank you very much for that. So again, I have lots of questions, but does anybody else? Well, we'll start with the first one, because actually I thought your second presentation that actually answered quite a few questions from the first presentation that I was going to have. So, but what was surprising was the amount of mental illness in children with a history of mental illness in the first cohort. Mm-hmm. Presume that was, in some senses, a positive selection of cases. But I just wondered whether that mental illness was, the common one in educated families, which sort of seem to predominate here. You think about autism, or I think about autism. Was that the predominant mental illness?
It wasn't actually the predominant mental illness, because our cohorts, the clinical cohorts that we recruited from, had clinics and services seeing children and youth with depression, anxiety, and then the behavioral disorders as well, such as ADHD. We had autism, which was part of the POND network, and that's the one with neurodevelopmental disorders. But psychiatry mainly had the internalizing disorders. So we had a good variety of disorders, I'd say, in terms of representation, which was, as you mentioned, was the point of that sampling.
Yeah, and so one of the things that was going through my mind with the first presentation was that what's trauma for one person is a pinprick for another. There's a huge subjective component to the trauma, which I think you sort of brought out in your second presentation. Yeah. And I guess there's two approaches that you might take. One is, should you protect them from the trauma, and protecting them is the best thing to do? Or should you increase their resilience and actually exposure to lesser traumas? Not talking about child sexual abuse or anything like that here, but is there a potential harm from an overprotective environment?
Mm-hmm. Oh, absolutely. I don't think we can eliminate stressful life events or negative life events. That's just part of life, and us developing the skills to be able to tolerate and manage these aspects and disappointments and so forth. But there are certain vulnerabilities that may make some people more vulnerable towards the effects of that stressor, whether it's a daily stressor or a traumatic stressor. So the pandemic certainly impacted everyone, but we can see that it had a disproportionate impact on those families and children who were already overloaded with other stressors and other concerns, right? And so I think that's where we can help at a policy or at a systemic way, but then we can also help at an individual level, which I stressed in the second presentation, where we can help with the strategies, with the coping mechanisms that we can promote in our clinics in individualized work and so forth.
And in my experience, people can have a great trauma and they can fight it and overcome it. But what tends to wear people down is a series of traumas. They may be much less, may not be so big, but just when one thing goes wrong and then another, and then another, and then another, you just sort of see people sinking into depression, just not with the size of the trauma, but just the number.
Yeah, there's a lot of evidence that daily stressors and hassles can have as much of an impact, and it's more so around the subjective appraisal than the objective event. So it's not the scale necessarily of the event or the nature of the event, it's how we view it and how we perceive its impact on our life that is more likely to impact our well-being and mental health. So certainly, yeah.
And then finally, from me at least, the social dimension. So if you are traumatized and isolated and have nobody to go to, you're being picked on, as it were, then presumably that's a much worse situation than if something bad happens to a group of people and they can share their misery, as it were.
So an interpersonal event versus a collective experience?
Yes, yeah. So the collective experience that you say, well, it's not just me that's being picked on, it's, everybody is suffering from this, or at least a group of us are suffering from this trauma. And so I'm not the only one.
So it normalizes the experience a bit more. So I think those two are very distinct. You are right. In my own research, I've looked at cumulative trauma mostly, which is the number of different types of trauma that one person has experienced throughout their lifetime. So I haven't actually looked at specific ones to compare the different types to each other and their impact. But there is quite a bit of research on collective trauma, which is quite separate in its impacts because it can increase the risk then for individualized or individual level or interpersonal traumas as well, and intergenerational trauma. So it becomes a bit more complex, parsing out the effect of what's leading to what. But that would be very interesting as an exploration for future work, for sure.
Oh, thank you for answering all my questions.
Happy to. I see a question from Hamish in the chat.
Okay, yes, in the chat.
And whether I modeled the effects of single event trauma exposure from CPTSD multiple exposure patterns. No, I have not looked at single event trauma exposure. So I've used cumulative trauma exposure as a continuous score. I did not look at the impact of a single versus multiple trauma exposures, but something to explore with the data.
Sure, it's just a little bit related to just this accumulation of effects as well, because a lot of the percentages you could see that it looks like that sample would have had a subset who did have multiple exposure, and whether that just accounted for more variance in your model, but perhaps that's for next study rather than post hoc analysis of what you've already done. But Thanks. I think actually Rona's question was ahead of mine. So
yes, yes, it was. I wasn't looking in the chat. Yeah.
Oh, sorry, I didn't see the question.
Yeah.
Wondering if there was any information on the impact of schools in the first study. Yes, actually, so there's a completely different study and line of research using this project and the data from this project looking at school closures in particular. It's not something I included in mine because we didn't have data at the time about school closures, but we did see in the other lines of research and studies that are currently ongoing with this collaboration that school closures had a huge impact on the families, particularly families who have children with mental health disorders, because they relied heavily on services through the schools, and for families with a lower socioeconomic status, because again, most of the services and social services they were accessing were through the schools. So when school closures happened in Ontario, nobody could access anything, not even these services. So it had a huge impact, unfortunately.
Okay, well, that's been a very interactive session, I think. Any more questions? If not, I'd like to thank Jala and Rona for two interesting and related talks in some way, and wish them all success for their next research adventure.
Thank you.
And thank you very much for coming all the way to Glasgow by your circuitous route. Okay, lots of other things come up in the chat, but it's all thank yous, I think. Okay, thank you. Bye for now.